Today we're going to talk about the health reimbursement arrangements as alternative for New Jersey employers. And specifically today we're going to present findings from the New Jersey Affordable Health Benefits Survey. And we fielded that survey, we sent it to small employers in the spring of 2022 in April and May. And that particular survey was focused on knowledge and interaction with ICHRAs and QSEHRA. So two specific alternatives, coverage alternatives. Joel Cantor, our director, is going to talk more about the survey in a minute or two, but I would just like to quickly acknowledge our partners in this effort, including our funder, the Robert Wood Johnson Foundation, who provided support for the survey through a contract to our colleagues at Wakely Consulting. And our colleagues at Wakely were partners in this effort in terms of the design of the survey, the fielding, and really we're great collaborators with us. So acknowledge them as well. Again, Joel will go into a little bit more detail about a lot more detail about the survey and sort of the genesis of the idea to do this survey. But I just wanted to also acknowledge our industry partners in this effort, the New Jersey Business and Industry Association and the Employer Association of New Jersey. And John Sarno and Kyle Sullender is on our participants on the panel joining us today, and really want to acknowledge their efforts and the efforts of their organization because they facilitated access to their membership list in order to advance the survey getting into the field. So it was really provided us an opportunity to have an audience to respond to the survey. So thank them very much, because it was their effort that really made this, their cooperation and their partnership, which made this possible. So thank you again to them. Now, just some quick introductions of the panel, and then I'm going to turn it over to Joel, who, as I said, is going to first do some level setting, orient us a little bit about where we are in terms of the environment of small employer coverage, both in New Jersey, and we have some national data about small employer coverage. None of it, frankly, I'm looking at the list of participants here. I don't think there's going to be a lot of new information for you, but we really want to contextualize and lay the groundwork for why it was important to do the survey. And then Joel is going to talk about specific findings from the survey. So on the panel, joining us this afternoon, Doreen Anthony. Welcome to Doreen. Doreen is Director of Human Resources at Laurel Circle, which is a life plan community in Bridgewater, and she has extensive experience in the healthcare fields, farm life and sciences and manufacturing, an extensive HR professional. In her former position, Doreen had some experience in working with employees to establish or work through offering an ICHRA option. And I think that's something we're going to probe a little bit more when we get to the panel discussion, her experience in that regard in a previous life. So interested in her perspective on that. Joining Doreen is Rob Saffow. Rob is a partner in Broker on Demand, LLC. Previous experience working at Concord Management Services, where I think he crossed with Doreen, and also QualCare. So, and Rob was also president of the New Jersey Association of Health Underwriters through 2019 to 2020-21. So, 2-year stint as leader of NAHU. So, Rob is a seasoned professional and expert, so welcome to him as well, and thank him for joining. John Sarno, who I'm sure most of you know John. He's president of the Employers Association, focused on helping small employers with training, advice, and access to benefit plans. And again, John has been really working shoulder to shoulder with us on this project, in addition to, again, facilitating access to the membership at EANJ. He's really been a thought partner with us as we conceptualize this project. Almost going on probably a year ago, we started talking about this. So we really appreciate his support. And Kyle Sullender. Kyle is the Director of Economic Policy Research at NJBIA. And prior to that, he was Executive Director of Focus NJ. So we're certainly glad to have BIA represented and have Kyle be working with us as we have gone about trying to disseminate some of the findings from this survey. And finally, and certainly last but not least, Joel Cantor, who is the Director of Rutgers Center for State Health Policy, founding director, is also a distinguished professor of public policy at the Blaustein School here at Rutgers. And he is a nationally recognized expert in coverage and access policy. And I know many of you, if not all of you on the call, certainly know Joel's name. So We're going to get back to the panel discussion after Joel walks us through some of the slides and orients us to where we are in terms of the state of small employer coverage. We'll come back for the panel discussion and the Q&A. So Joel, do you want to lead us through the slides, please?
Sure, let's go to the next one, please. Great. So first of all, let me add my thanks to colleagues from EANJ and BIA, and also thanks to Robert Wood Johnson Foundation and our colleagues at Wakely, RWJF, Kathy Hempstead in particular, and also the folks at Wakely were more than just sort of the bankers on this project. We just got a lot of tremendous input from them. But as I always say, you know, any errors and omissions are those who belong to those of us who ran the data. So don't blame them, blame me. So let's go to the next slide, please. So first I have just a few background slides, and this one is sort of, to this folks on this call, like extraordinarily basic, but you know, let's start at the beginning. This is how we do health insurance in the United States. You know, we're about 2/3 private insurance, and that's mostly driven by the employers. The next slide is the same thing, but for New Jersey, where we're even more heavily dependent and reliant on the private health insurance market. That's largely because we're a higher income state. We have employers that offer health insurance disproportionately so compared to the rest of the country. So this is a really important topic. Obviously, we're trying to minimize that little gray slice, the uninsured, and make the markets work in the private sector. And that's really what we're about today. A little bit more background on the next slide, please. So I show this with a little trepidation because this webinar is not about, we're not going to talk about what's up with the regulated small employer health insurance market. That's a big topic for a lot of reasons, and something that I know many of you live every day. But it's really important background for these HRA options as we think about creating options for small businesses, and not just small businesses, but small businesses especially, to help them help their workers gain access to affordable coverage and ultimately affordable healthcare. We are at a sort of the moment where we have roughly the same number of people in the individual or non-group market as we do in the state-regulated small employer market. I think the next slide, at first glance, is going to seem a little inconsistent with this, but I think raises some good questions. So this comes from a national survey conducted by the Agency for Healthcare Research and Quality. It's a survey of employment establishments, and it asks, do you offer health insurance to your workers? And this is the number of small employers that offer it over this time span. And as you can see, New Jersey is quite stable and quite favorable relative to neighboring states and the US as a whole. And what this suggests to me is that employers are still in this game very much. They do want to be offering, that they're finding ways to do it, but maybe a little bit less through our state employer health benefit program than they did in the past. So with that as background, let's go on to the next slide. So our topic for today is to talk about these two comparatively new health reimbursement arrangements. It's with some humility that I give you background on this, because I know there's probably of the 50 or so folks on this call, 49 who know more about this than I do. But let me, bear with me, I'll go through what I know, and then when we get to our panel, they'll either correct me or fill in the blanks. So first of all, these are fairly new arrangements, as you can see on the slide. They have been received by stakeholders, lobbying groups, and representatives for employers, employees, and others with some mixed enthusiasm, shall we say. And some skepticism. And we, if we want in the Q&A part, we can talk about what those feelings are. But I think it's just important background to know that these didn't land with a universal embrace or a universal rejection. A common theme here is that these mechanisms can be used to offset workers' costs in ACA compliant individual market plans. So they can do more than that, but that's an important theme here to keep in mind. And as we saw those two lines in the individual and small group market, I think there is more fluidity between those markets now, and some changes from the ACA and other things that led to that. So the QSEHRAs, the qualified small employer HRAs, were enacted as part of the 21st Century Cures Act in 2016. They apply only to small firms. If they're offered, they must be offered to all full-time employees. Employers can contribute up to a capped amount, so there's a maximum contribution. If they do offer it, the employer may not offer a group plan. So it's really an alternative to a standard group plan. Importantly, I think employees may combine dollars out of the QSEHRA account with ACA premium tax credits to buy in the individual market if they're eligible for tax credits. ICHRAs are different. So they were created under federal rulemaking authority in 2019 in the Trump administration. They reversed a prior ACA rule that prohibited employers from using HRAs to pay individual market premiums. Generally, they're more flexible than the QSEHRAs. They apply to employers of any size. They can be offered alongside a group coverage option within a given employer. They may be offered to specific classes of employees. They don't necessarily have to be offered to all employees. And the list of classes of employees are specific and kind of long. So they can play a niche role. There's no cap on employer contributions. So they're very different from QSEHRAs along those features. However, employees using ICHRA dollars to pay for marketplace coverage cannot also use premium tax credits. So it's a one or the other thing. So that's different too, and that's a little less flexible than the QSEHRA. So that's the quick background on these arrangements. So let me now turn to what we've learned through our survey. Sorry, I had a couple more slides. Before we do that, so there are lots of these are new arrangements. There's lots of questions. So this is really the questions that we had in mind when designing the survey and thinking about this panel is, what's the potential impact of these on the small group and individual markets? Are they fragmenting the markets? Are they augmenting the markets? What incentives do brokers and health insurers have to deal with these products? And we can't really get at that in the survey, but we can in the panel. What awareness and uptake or take-up is there among employers? And that's what the survey was really about. For those who have taken it, what's their experience been? We tried to get at that. And then what are the issues? What are the regulatory issues and the policy issues here? And that's sort of the bottom line, at least to the extent we can reach a bottom line today that we want to talk about. Next, please. So this project is one of an array of things the Robert Wood Johnson Foundation is doing around these options. They're doing a national outreach and awareness campaign with a group called Public-Private Strategies. They just kicked that off in October. They have done some additional research, and I think this might be a link. So if you can send the slides, you'll be able to get to it. And then, of course, the last thing is our project. So now I think I'm ready to go on. Thank you. All right. So here's what we did and what we found. and then we'll save as much time as we can for the panel. So next, please. So here's the project team. You met Margaret and me. Jolene Chow is our analyst working on this project and did all the hard work putting this together. And Michael and Michelle from Wakely were just tremendous supporters, not just in the contracting, as I mentioned, but also in helping us think about the right questionnaire and so on. Next, please. So we've been through most of this. I mentioned Kathy's important role, Alan Monheit, who I think is in the bleachers in the audience, advised us on this as well, professor of health economics at our School of Public Health. And then, as you can see on the slide, some of the team at the Agency for Healthcare Research and Quality were really helpful as well. And they do the MEPS survey that I showed you earlier with the offer rates. And we borrowed their questions shamelessly with permission because they're really well tested and well fielded questions. So we mirrored their methodology to the extent we could, and they were great advisors on this as well. And then we also have been introduced to Kyle, John, and Robert. Chrissy was, I guess, has moved on from BIA, but was really instrumental in working with us at the front end of the project. Next, please. So what did we do? So we designed this to explore employer familiarity with and adoption of these two specific HRA options. It was an online survey distributed by our partners at BIA and EANJ to their pre-existing lists. So it's not a random sample, but it's a very broad sample, as we'll show you. It was conducted April through in May, earlier this year, and we ultimately had 184 responses from firms with at least one location in New Jersey. And you can see across the bottom row here on this slide that it was the people actually answering the survey were in a position to answer the survey. So about a third from the HR departments, 20% were owners, 12% CEOs or other senior executives, and then the remainder in other kinds of roles. It doesn't mean they knew everything about their firm's HRA options, but they were in a position to know a lot. So let's go on. So we had responses from every county in New Jersey that distribute across the state, with a little bit more representation from the central Northwest and the Northeast regions, Central East. So it's a pretty good distribution. It doesn't map exactly to the population distribution, but it's essentially where the people live. So that's a good reflection of the sample. Next, please. So in order for us to sort of gauge the nature of our sample and the folks who are responding, this shows you the distribution by a number of employees. The gray and the diamonds with the gray numbers represent what's in the medical expenditure panel survey, that national survey that AHRQ does. So it looks like we are slightly underrepresenting, or we are underrepresenting the smallest firms and slightly overrepresenting larger firms, which doesn't surprise me because it's a health benefits survey. And if you're not offering health benefits in the tiny firms, you're not going to respond. So, but it's still a pretty good distribution. Next, please. So we had pretty good representation across these broad industry categories. Again, the gray is from the national data for New Jersey. We do seem to be underrepresenting retail and other services a bit, or actually quite a bit. And not everyone in our survey gave us enough information to classify them. But in terms of professional services, we do well. Goods producing sector, we actually do better in terms of representation. Next, please. So here's the bottom line, the slide everybody has been waiting for. This is puts together answers to questions: do you offer one or the other? And if not, how likely are you to offer? And the blue part of the bar shows that a tiny number actually offer, and it roughly equivalent and still tiny numbers say they are likely to offer. So the light blue is likely, the lower darker blue is actually offering. So we can count these on two hands. The next bar over, the salmon color, are those who say somewhat unlikely in the light color and not likely at all in the darker salmon color. So a third or so say they're not likely. By far, the most common response was, I don't know, or they simply didn't answer it. So, and you'll see why I think that's the case in a moment. So let's go to the next slide. So of those who don't currently offer, these were the reasons they gave us, and they could give more than one here. By far, I mean, half the respondents who didn't offer answered, we don't know enough to decide whether to offer. So we have a educational a challenge here. The next most common responses, their broker or agent didn't recommend it. It was too complicated to administer. Employees aren't interested, or the respondent didn't feel that it was the right thing for their employees. It's a smaller number. Next, please. So those are we have a lot more data, but that's the essence of our findings. So just to wrap up this part of the talk, so we see rising premiums and declining enrollment for traditional employer-sponsored plans. Our survey found very few employers currently offer or plan to offer these flavors of HRAs. Lack of familiarity was by far the most common reason stated for not offering them, and leading to the bottom line that if people don't know about it, the first step seems to be to educate employers about their options. So I think that's what we have. We turn to the panel. Let me just pop open the question and see if is there available access to the survey questions and results? Yeah, I think we can share that. We have a final report that's nearly ready. I think we can distribute that after today's talk. Thanks for asking.
Circulate the slides as well.
Yeah, and we'll circulate the slides.
Okay. All right, Oliver, maybe take the slides down so we can see each other. And I should acknowledge a quick thank you as well to Oliver Lontuck and Joe Brecht on the center staff who have been helpful in putting this event together. And Oliver is our MC, if you will, and is responsible for the logistics. So thank you to him. Hi, Kyle. So to all of you, now we've spoken about, we've shared some of the results with you in advance, and we've given you some previews, but thinking about some of the data that Joel showed, anything surprising to you about the results? Or did it provoke any thoughts in your mind about potential next steps? What might be actionable? What have we learned from the survey, right? That's why you do a survey, to learn. So, John, I'll start with you. What were your reflections on the data?
Well, I'm not particularly surprised. So I think, Joel, first of all, let me say it's absolute pleasure to work with Joel and Margaret and the team. As I said offline, the center is an enormous resource to the state of New Jersey. I've been relying on the research now for almost 2 decades. So thank you for reaching out, and I really appreciate us working together. And thank you to the panelists as well, and those EANJ members that are attending. So no, I'm not particularly surprised. I think Joel had mentioned that the rule, and this is important, it's not a statute. So I think we could anticipate the next Congress codifying these coverages in a statute, but it's important to know that it's not statutory, it's a rule. And as Joel had said, there are mixed feelings and some degree of skepticism. And there's a good reason for that, because the rule repealed a previous administration where the litmus test was the Affordable Care Act. And so a new administration comes in and they campaign in part on repealing the Affordable Care Act. And then they issue a rule which repeals the prior administration. So the first 3 Ps, the first, politics, caught up in the din of the preservation as opposed to the elimination of the Affordable Care Act. Second P is policy, right? So in many states, the regulators view their role as protecting the state small group, what I would call a monopoly. Many states in the country, there's just one major carrier. New Jersey, you have maybe 1 or 2 major carriers. I like to call it a monopoly. So when these coverages were first introduced, I attended a panel with state regulators, which combined both the policy and the politics, and they were foursquare against these arrangements because it was perceived as undermining their role in preserving the small group insurance monopoly. Third is profits. What's in it for the brokers? What are the commissions, if any? So I think that given the sort of the way it has been rolled out, the way it has been submerged in a wider policy, political context, and perhaps the lack of incentives for brokers to present this as an alternative to their clients, I'm not surprised with the results.
Thanks, John. So since we're talking about brokers, segue to Rob. What are your some of your reflections and thinking about what the broker's role is here and how that perhaps may have evolved when we look at some of these alternative options? So what are your thoughts?
Sure. Thanks for having me. First of all, very happy to be part of this program, this project. Yeah, I have zero surprise. I'm zero surprised to see the findings on this study. Saw a third of the participants not likely to offer these programs. We saw over half don't even know about them, and like I said, this is exactly as I would suspect. The big push around these programs, let's also take a step back for just a second here. The big push for these programs came about when there was a lot of changes happening in the market as it is, right? So you had some carriers exiting the market. You had a lot of disruption in the small group market. Some were going to alternative types of plans, not just these QSEHRAs were being considered. So, at the end of the day, I think there's a lot for employers, brokers, employees to consider. There's a lot to understand how it works, and once you figure out what's best for your business or your client, now you got to figure out how to do the implementation on such programs. So I know I'm saying a lot, but long story short, to go into a program such as this, first of all, it's not for everybody, but for those who it's for, I wouldn't go into a program like this completely blind. You need a professional to guide you through it. And that professional is a broker. And you know, at this point, not all brokers, I would say, support this as an option, because there are positives and negatives, right? So you got to find that subset of clients that is perfect for it. So I have zero surprises from the survey results. Yeah.
Doreen?
Yeah, I mean, I was not surprised either. And to, sort of amplify some of what Rob is saying, health insurance benefits is such a complicated undertaking in any case, even when the market is stable, even when there's nothing going on in politics or elsewhere. And certainly if the brokers in this area are not promoting it, where else is the small employer going to get the information? Because the small employer, particularly the individual who's probably in charge of making these decisions or looking in and making recommendations, has many things on his or her plate. And this really would require, kind of expert level information before one could make such a recommendation and even, take it to the next step. So health insurance overall, full of acronyms, not easy for lay people to navigate. So no, I'm not surprised at all to see that, our survey respondents were kind of shrugging, right? Because it's a big deal.
Seems like there's a level of complexity, and we know health insurance is complex at baseline, but there is a level of complexity and nuance here, and certainly devil always being in the detail. Kyle, from, I'm going to go out on a limb and say probably not big surprise, but what were your thoughts about the data?
Yeah, well, thank you. And first of all, let me, of course, say thank you to everybody for being here this afternoon, and thank Dr. Cantor and his team for inviting us to participate. And it's been a great partnership since the survey was launched. From my perspective, it strikes me as almost a chicken and egg situation. When we talk about these responses, you are put in a position where, with such a lack of information, it's difficult to know whether or not the investment of time and effort to learn about these alternative arrangements is going to be fruitful and actually lead to something that's worthwhile for your organization. But at the same time, if you don't take the time and effort to get that information, you'll never actually know whether or not it could be the right fit. And so it seems that really getting that information out and finding a way to ensure that employers are aware and that these alternatives are out there, it's difficult to ask them to take the reins on it when they don't know that there's going to be a benefit there. So hopefully we would be able to find a way to help do that as well.
Thanks, Kyle. I'm going to segue and kind of transition between some questions I have as the prerogative of the moderator, but also to minding the Q&A box. There's Linda asks a question that I think dovetails off of what Kyle is saying. So what is potential, do any of you know, role of technology? Do any of you know of any tech platforms that are being developed to make the purchasing process more consumer friendly, so that, trying to facilitate some of these transactions, understanding education? How is that going to happen? Is technology, technology is apparently the answer to everything. What's the role here? Any specific insights?
I know Rob does, so I'm going to let Rob go first.
Thank you, John. I'm going to say yes and no, right? So absolutely. If the process could be simplified, this conversation would be a lot different. The problem is there are plenty of platforms, there are plenty of vendors that have the capabilities and are willing to to put those capabilities forward to a consumer-facing platform. There's a lot of data points that need to cross, and there's a lot of data points that need to talk to each other, and we're not there yet. That's not where we're at. So until we could do an end-to-end enrollment from a platform through, to get covered NJ to the carrier, because now we're adding another point of complexity. Until we could tie that together simply, an easy to use platform, it's not going to catch as much steam. Other states have done it. Other states have done it successfully. We're just not there yet.
What do you think the barriers are then for New Jersey, or, what's, is it lack of interest, will, appetite, funding? What might be a barrier?
Yes.
All the above?
Yeah, all of the above. So right now, Get Covered NJ, it works, right? It's a platform. It works, there's really no reason to upset the apple cart right now. Other states use other third-party platforms that integrate with these vendors that could offer these types of programs, and it's working great. I wouldn't even say it's a lack of funding or a lack of desire. I just think we're not there yet. I think Get Covered is only 2 years old. I think we're still exploring the capabilities itself in the Get Covered platform. And I think those conversations are going to evolve in the coming years. Yeah.
John, did you have thoughts about the technology?
I don't think technology drives, at least not at this point, will drive if there is going to be uptake, will be driving the uptake. So when the rule was first issued, the purpose and the expectation was that 800,000 small employers would be the first adopters, which would cover 11 million workers and families. Well, small employers have not adopted for reasons that we're discussing and survey has pointed out, not because of technological barriers. As Joel pointed out, the smaller the group, smaller the employer, less likely they are going to be offering coverage in any event. So who are the adopters nationally? They're all larger employers. They're all defined as large employers under the Affordable Care Act, which adopt these coverages to meet the ACA's requirements of both affordability as well as quality of coverage, the coverage mandates. And so who has had access to information, not the smaller group, not the smaller employers, but the larger employers have so far had the bigger uptake. And that's not a technological issue, right? And then finally, I would say the subsidies that are involved. And the subsidies are the tax code, right? Because employers provide coverage. I know we like to talk about investing in employees' health, and that's absolutely certain. But the employee's contribution is tax deductible, and the employer's contribution is tax deductible. And so that's the biggest subsidy one of the biggest subsidies in the world, right? And so small businesses may not need or want the tax subsidies that go with both small group as well as these programs. So I think for a larger group, for an employer, it meets a lot of needs because it empowers employees and we can talk about that later and how that's done, but it also preserves the tax benefit for both the employee and the employer, and that's not a technology issue.
I think Margaret actually lost connectivity, so I'm going to step in. She said, Zoom, I got a text, Zoom went down here. So Oliver, could you reach out to her and see if you can help her get back on the system? In the meantime, let me turn to some of the additional questions that we see in the Q&A. I think Rob may have made some reference to this, but one question from somebody named Anonymous is, do other states which may have taken more affirmative steps to make these models available see higher take-up rates? I'll just say that I'm not aware of studies like this, although we're talking with some other states now, but maybe you know from your networks whether there are states that could be seen as models for educating the potential customers for these.
I can't talk to specific states in terms of data, but what I can tell you is I've spoken to a lot of individuals, and I'm just going to talk about individuals, the individual market for a second here, because those are the ones who it's the same interaction if they have a QSEHRA and they're going to go buy their own health plan, right? So a lot of the folks I speak to would be completely, they would just completely stop dead in the process if they didn't have a professional, a broker to speak to. And it goes even deeper than that. It almost goes into, you know, how we educate people on insurance and on healthcare. And we should start as young as in high school, because there's so many people I speak to who have zero clue about where to go and what to look for. So, you know, with that said, anything we could do to make it easier, just, I think will spur that uptick. So before we had Get Covered, a lot of brokers here in New Jersey used a program called Health Sherpa. There's some other ones, and a couple other states have access to that. Many states have access to that. I know me personally and a lot of other my peers, we did really well with that technology because it was really simple to use. You know, can't speak to specific states, but I do know from experience it's helped in the past.
Real fast, Joel, I have a map, which may shed some light. And apparently there's a relationship between cost and what the states are doing. And so the key issue is the cost of an individual plan and the cost of a group health plan. And so it really goes to the savings that an employer can incur. I'm not saying that's the only factor, but that's a big factor to the data that I'm looking at. So for New Jersey, data unknown. So maybe there's some work to be done here in terms of, you know, research and, you know, drilling down. But apparently California, there's a big distinction. It may have to do with individual subsidies that are enhanced in California, where there's a big distinction between the individual cost and the group cost. And so where it becomes cost effective for individuals to buy their own plans, cost effective for both employer and the employee, I think that is going to correlate with what states are leaning into the programs.
Yeah. So Margaret is back. I'll take one more question while her technology aligns. Sounds like the internet went down in the office.
It is, but I can go on my laptop. So I just switched to my laptop.
Okay, great. You know, this is the new world we live in. There's there's a bunch of comments that folks are dropping in the Q&A as well, and I'm not going to do justice to all of them. But one from a broker who has used these and notes that the extra state subsidies in Get Covered, NJ, have been an obstacle to small businesses using these vehicles. Other comments, someone else who has some ICHRAs in place, let's see, notes that, you know, as others have commented, that technology is absolutely needed if uptake is going to not her words, but if uptake is going to get off the ground, that it sounds like it's very challenging to, even for somebody who is knowledgeable about these things, to make them work for their clients or for their companies.
You know, Joel, you just made a great point, and I alluded to it earlier that these HRAs are for a very specific client, because I've had personal scenarios where, you know, a smaller employer, they wanted to offer the QSEHRA, and their employees went to the marketplace themselves and saw that they could get a great subsidy if they didn't accept that QSEHRA, and all of a sudden they start chatting with the other employees at the company, and nobody's going to elect the QSEHRA, and everyone's going to go get the subsidy, and now the employer is not offering any type of group health plan. So yeah, it's a very, very specific client that this works for. Employer works for.
Yeah. So one
Sorry.
question, go ahead,
Yeah.
are you ready?
Yeah, no, sorry,
Back to
just
you.
the internet is down in the building now, so somehow I'm on my laptop. I don't know why it's working with the internet. But Joel, did you see Linda's question on the age bands? Did you?
I
hit
did
that?
not.
Okay, so for the group, yeah, how does
Go
our
ahead.
age rating impact this conversation? So thinking about 3-to-1 for individual and 2-to-1 for small groups. So what is the thread then with regard to the age band distribution? And any impacts here?
It's a tough conversation.
Yeah, there's an, well, yeah, there's an
Winners and
impact.
losers, yeah.
The employer, the EEOC has issued an advisory opinion on these plans. I don't know if this is going to answer the question. The 2-to-1 has to do with the guaranteed issue in small groups. So I just don't see the relationship between that and what we're talking about. But with regard to age and these plans, so as Joel had pointed out when he was going through, you know, summarizing what they are, the employer puts in an amount. And it does not have to be equal. The employer can adjust for both age and number of dependents.
Right.
And the EEOC, actually the EEOC answered the reverse issue, which is what if you give everyone the same? And of course, older workers would have presumably higher healthcare costs. Would that be discriminatory? The EEOC's position is it would not. Keep in mind, these are not ERISA plans, and these are not insurance plans at all, really, as regulated by state insurance laws. So the employer could adjust, could make a very customized, very flexible contribution, not only based on full-time, part-time, seasonal, salary, exempt, non-exempt, classify employees, you know, in different ways. But you can also vary your contributions by age and by dependent. So it could be very customized, flexible per employee class.
So John, just to react to that a little bit, that's true of the ICHRAs. I don't think it's true of the QSEHRAs, right? Which it has to be everybody has to be, and you can't carve out
everybody. Yes, everybody. It's one or correct. It's all or nothing.
Right, but the ICHRAs have
which may be a barrier.
That's right. Sure, it is. It's a very high bar.
Yeah.
I had another question, but it escaped me. I can only keep one thought in my head at a time. So back to you, Margaret.
Okay, thanks. Dorian, you and I had spoken a little bit earlier, and I was wondering if you could share some of your experiences. I alluded to it in the introduction, but in a previous life, you had in a position you had worked with employees to offer an ICHRA. And again, smaller scale, and you were describing it a little bit. Can you share that experience, and both in terms of sort of the complexity of trying to determine who it was in the best interest, was it in the best interest for the employees? And I know there were extenuating circumstances with the group that you were
Yeah.
dealing with too. But this thread that we continually hear about the complexity of it and the education and that people don't know about it. Well, how do we get there? Should we get there? I mean, I guess that's the other question. Is this, is this an option that is worth pursuing? And obviously, people can have different opinions about that, but clearly, how do we get to the education piece? And it seems like you've had experience in working with this. So can you tell us a little bit about that experience?
Sure. So as you and I talked earlier, I did have occasion to implement an ICHRA program, but I want to point out that that was a very specific point in time. I was working for an organization who had had a significant impact because of COVID, and there was a market downturn, and business conditions were unfavorable. So we were unable at that point to offer group coverage. So the ICHRA was, a fantastic mechanism in order for us to do some quick fixes for the employees and kind of support them through a difficult time. What was interesting though, and Rob and I were talking offline about this, that particular population was, to Rob's point, the ideal specific customer, because these were very sophisticated workers who had knowledge of the industry, of the healthcare industry. And so they were not scared off by the navigation, the, getcovered.nj. They were not intimidated by, just the ins and outs of it. And I think about now in my current role, if I were to find myself in a similar situation, it would be a completely different arena. There's a lot of things to look at. And while I can certainly see, and I certainly saw, that the ICHRA option was so appealing for the employer to get out of the day-to-day of choosing coverages and then being kind of the face of those coverages, and all the work and time that goes into those exercises, and simply to then maybe put money into an account and say, okay, we're going to not do all that work now, but we're going to leave it to the employees. A lot has to be unpacked. First, I think, have to look at what are employees expecting, and not all employees in all industries are going to even have an appetite for this, because, Joel's earlier slide of 71.2% of employees are covered by a group plan. That's the expectation when you offer jobs to people. In many cases, they expect that to be part of the package. And when that isn't part of the package, we have to be really ready to explain why and how our solution is at least as good, if not better, right? And we have to have employees who understand or are able to be educated to see that value, and then understand that they have the flexibility to go purchase a plan that's right for them. So the right level of employee really has to be there for them to understand this, because, you can put the best program in place, you can think it through, you can put as many dollars towards it as you think you can. But if the employee perception is that it's lesser than your competitor is offering, or you don't care as much because you're not going to put forth that effort, it's not going to be perceived the right way. So there's a lot here to unpack, but that technology piece is crucial, because I can, as the employer, say, here's my side of the ICHRA, here's what I'm going to put in for you, here's what it means for you. Now go and use these tools, right? And go find a plan. I'll try to help you to the best of my ability, but I need that partner in a broker or a vendor to make sure that side of the employee transaction is as solid as the part that I can control. So I know that was a lot said.
No, tremendous insight, so think of, Doreen is just a super HR professional. And so I rely on her advice on these matters, and I'm going to rely on it right now. So picture also the transition, right? Because there's a generational issue at play. It's an organizational, cultural issue at play, as Doreen is getting at, right? So think about the employee's perspective. You've had the employer you know, being,
Yeah.
you know, paternalistic. I don't mean that in a disparate way, right? The employer goes out, does the shopping, does the pricing, does the negotiation, does the purchase, and then says to the employee, here it is, right? So the employee's role has been passive throughout. And so maybe with a startup, with a younger group, a younger cohort that's used to being more individualized in their purchasing habits, maybe it works, right? A little better. But then you have an employee maybe for 10 or 20 years where the employer has been doing all the work. We do this with 401ks, my only point here. We do it with 401ks. Totally self-directed. The investment advisor comes in, educates the employee that they have a menu of options. They have access to the advisor. They're all online. That technology, the suite of the dashboard is all available in a 401k. So totally doable.
Do you, is it really just sort of a collective sense though, that what is the trepidation, Doreen? I mean, I know you said, some could be an age issue. It could be, you know, preferences that that employees have, but you know, what is their biggest reluctance about trying something new? Right. And trying to introduce change. Change is difficult for all of us, right? And, you know, there is, as John said, sort of this view that what we connect with employer sponsored coverage, right? Some of those decisions being made, but it's the responsibility. So sometimes people want that authority over and that agency over their own choices. But do you sense that there can also be apprehension about that because of the gravity of these choices? Sometimes it's easier to have somebody make those choices for you. Like, where's the push and pull there?
You know, completely. And I think that really becomes very person specific. It's really hard to answer that in a general sense because there are some employees that have some comfort in making that choice. But to John's point, you know, it has been the paternalistic role of the employer for so long that there's almost that expectation because, you know, that's just the way it is. You choose and I sign up, basically. Health insurance is tricky. You know, in my current job, we just went through open enrollment and I cannot tell you how often I find myself explaining even the very basics of what an HRA is, regardless of whether it's an ICHRA or the QSEHRA, just the regular HRA component of their health plan. They don't know how to use it. They don't understand always what's eligible, what's not, what's this pay card. There's so much around just that, just those pre-tax spending accounts that have not, I think, gotten the traction in the education as much as I would like to see that have been the case. And I did my best this year to really, you know, focus on that one aspect because I think people understand now networks and you know, various copay structures, deductibles, but those pre-tax spending accounts, whether it's again, FSA, HSA, dependent care FSA, you know, there's so many alphabet soup, I think is the term you used earlier, that it gets to be static. And so you really need to look at, I would say, person by person, and I would do an impact analysis. I mean, if I were looking at that here, I would be looking at, you know, let me look at my actual census of enrollees and who's single and who's family and what are their income levels, because I know what I'm paying folks, and how would they be impacted, you know, if we were to implement a program like this. And so I think those answers are just so personal.
Yeah, one last point, Margaret, great question. I think another good analogy is Medicare, right? So for 40 years, you know, my employer's been sponsoring the plan. And now I enroll in Part A, Part B, and I'm a deer in the headlights, right? Because now I'm on my own trying to pick an Advantage plan. And like, I don't know what I'm doing, right? And so, but we do that because we have brokers and carriers that make a lot of money selling and enrolling people in those Medicare Advantage plans, right? So so the individual has counsel, has comfort in getting the right advice to take them through the process. So not a perfect analogy, but Doreen is right. If you adopted something like this, it's not okay, over and done with, employees are on their own. There's still going to be that employer function to educate and to bring in the resources, whether it's group meetings or individualized counsel. And so again, it's another possibility for a win-win. So we offer group healthcare coverage to get back the employee's loyalty to a certain extent. And so if you offer an individualized plan, consumer-driven plan, you do not necessarily need to sever that loyalty, because the employer, just like the 401k plan, just like an employee assistance plan, still can invest and support that employee.
May I ask a question? Or I'm not sure it's a comment or a question, but I guess it's a question. So, sorry, I'm an academic. I guess listening to this, I'm wondering if these products are really potentially useful right at that margin between where an employer is definitely going to offer a group plan. The market demands that they won't be able to attract and retain workers without it. They're going to do a group plan. And those that could never do it because they're low-wage firms, operating on thin margins and so on. And right in the middle are those that kind of want to do it. They know they could do better for their employees, but are scared to death of the sort of premium spirals and would like to do a fixed contribution plan, offer some choice in the individual market, help their employees in some way without breaking the bank. One question is that, are we talking about the best case scenario here? Is these fill that niche, or is it more than that?
Oh, that's a loaded question. So I look at it actually on the opposite end of the spectrum. I look at it as the employer who just so fed up with the process. The premiums are skyrocketing.
Yep.
There's questions about if his group is even eligible or not, and he's almost ready to wash his hands with it. And this employer is there. They would rather just say, you know what, everybody gets $500, go spend it however you want. That's kind of where I see it fitting in to that employer that's just ready to pull their hair out, and they've had enough with the industry, so to speak.
Yeah, I slightly, my take is different. Clearly that could be the case. But my take on that is an employer that's really focused on talent management and having an organizational culture where they are to a certain extent competing for the best and the brightest. And so there is a role to be played for employees, governing their own choices. And so, at least with the individual plan, the HRA, you can still offer a group health plan, but can have this as a possible option. Or if you wanted, you can do one or the other. And again, as I indicated earlier, you can do something for the warehouse people, you can do something for the headquarters, you can do something for the transportation distribution. You can break down your entire organization geographically, as well as by division, by job category. And so I don't see this as the race to the bottom. for the employer that wants to wash their hands. I understand that will be the case, but I see this as the employer who really wants to do an uplift and really wants to drive a culture based on autonomy and choice and and teamwork. So interesting take that we would come at it from different angles.
That's why you have diverse perspectives on panels.
Yeah, that's right.
Just a couple of comments really in the Q&A, echoing back to the comment that it really employer and employee education is key. One of our participants says it may be a good alternative for an employer who has poor claims and high rates, and an employer who has very low participation in the medical plan where carriers are not interested in writing business. Next question though, how do group plans tend to compare to individual market plans? How do group plans tend to compare to individual market plans in terms of coverage? Do the group plans tend to be on the higher end, similar to golds or platinum, or the lower, akin to bronze plans?
So the answer to that, I'm assuming we're talking about ACA group plans.
Right.
We're talking about the insured group plans specifically. So
metallic tiers.
Yeah, so the plans that are on the individual market have a mirror image for the most part in the group market as well. Where you'll see more a little more diversity in the group market plans is there'll be some plans with more out of network coverage. There'll be some national access options, and it is true there will be more plans with lower deductibles or stronger coverage, so to speak. So that's the big difference. There are a lot less options in the individual market.
Yeah, if I could just add to that, we're in a period where the subsidies in the individual market have been enriched in many ways. And so somebody asked the question, what is the family glitch fix due to all of this? And that's another way where a certain class of people will get better subsidies in the individual market. So that draws people into that market, and they could upgrade their plan. They could go from bronze to silver to gold, because the government's paying for more of it. So it's a fluid situation under the current circumstance during the public health emergency with all the extra subsidies. I think the floor has come up on the quality of or the generosity of the individual plans, which may be at play here as well, in drawing people into that market, whether or not they have an HRA related vehicle to help pay for it.
Right.
So Rob, let me ask you then, with regard to the subsidies. So on the individual plan, the employer puts in their base amount. The employee can then match that with a subsidy on the exchange.
As far as I'm concerned, once they have QSEHRA offering, the subsidies don't apply.
No, the individual.
ICHRA?
The ICHRA. Yeah. So they compare. I mean, they up to full. Full coverage.
So it can really drive that. Now our survey, Joel, we were underrepresented. The only area that we were underrepresented was retail, and I think that's because both, at least EA&J's membership is not going to have a lot of retail in our membership. But I would think that with that workforce, you can do an individual plan, and the employee can then go to the exchange, as Rob just said, get the subsidy, and you might be able to really drive down costs that way.
Interesting. Yeah, I do think that the membership of both EA&J and BIA are going to be firms that are much more interested in following and understanding health benefits and other kinds of benefits. They're a very engaged group. So I think the possible market for this, we might have missed a little bit. Those
Yeah.
who are not engaged, that are looking for something simple. Not to go into a methods rabbit hole, but we may have a little bit of a blind spot there.
So I'll ask a question I think Kathy might have asked if she was here, our colleague Kathy Hempstead from the Robert Wood Johnson Foundation. So, and Kathy looks at, obviously she had an interest in what's going on in New Jersey, but she also looks at other states. And I know there are a couple of colleagues, I don't know if he's still on, but Doug McCarthy, a colleague in Colorado, who is involved in this work out there. But where do you think we're going to land in a couple of years? Where are we going to be with ICHRAs and QSEHRAs? And is this something that, you know, certainly for the center, as those of us, those of you who have worked with us and familiar with our work, we had done an extraordinary amount of work in the last, you know, particularly with the transition and the implementation of the ACA with coverage and access. And frankly, over the last few years, we've really been focusing on some implementation work, but also looking at health systems research. And we've been we're pivoting more and really kind of emerging ourselves, frankly, back in coverage and access. So, you know, what would be interesting and what are your thoughts about sort of, we talk about the additional education, we talk about maybe where some of the gaps are, but is this dog gonna hunt in a couple of years? I mean, where are we at? And where do you think we're going to be in a couple of years? Keeping in mind, there's a lot of work going on. There's a lot of attention, obviously, in the small employer market. There may be our colleague Linda Schwimmer's on the call, obviously asked a few questions, but I know that work is continuing. And full disclosure, we're working with Linda and a sort of an informal team to think about some you know, options. I know Senator Vitale and his staff are looking at dropping some legislation or amending some legislation that was already dropped. So what's your prediction of where, particularly on HRAs, is this the future, or is this sort of not going to have legs?
Well, this is not my prediction. I talked to somebody who's a lot smarter than I am, a policy guy who's in DC, who this is all he does is follow this stuff. And he's told me, he knows, I told him, hey, I'm going to be on this panel. What can you tell me? So he tells me that, as I had said earlier, we're dealing with a rule, right? Department of Labor rule and a Treasury rule, which is kind of the part of the background noise. And so he's pretty confident that there'll be a few things passed through Congress, this being one. There'll be some laws on association health plans, some clarifications, maybe one or two other things. So he sees this being, these plans being codified in a statute. I think my own sense is that we're way beyond the ACA litmus test, and that there could be a consensus and it could be enacted. So I think that once it's statutory, then it gets much more visibility, and it can't be ignored by the stakeholders. And then you have the red state, blue state thing. And so you have regulators in half the country, let's say, that view themselves as proponents of choice and alternatives. And then you have those states who are champions of state monopolies. And so I think it's going to be uneven nationally. But if it's a federal statute, then I'm not quite sure what kind of reach state regulation will have.
I have two comments. Second one kind of piggybacks off what John was saying. First, these programs remind me about a decade ago, maybe 15 years ago, when the high deductible health plans came out. And everyone was saying, no, those aren't going to take off. Nothing's going to happen there. And
look where we are.
Look where we are. Exactly.
Yeah.
Exactly. exactly. And that's, I kind of put this in that bucket. You know, if the proper education is done and it becomes easier to administer, and that's my one point. The second point is to what John was saying. Definitely, it's gonna depend on policy and legislation. That's going to be huge in the uptick of these programs, and you know, to what extent the states or federal is going to support and want these programs, or is the agenda more towards supporting the small group?
Yeah,
really.
I'm sorry, Rob.
No, go ahead.
A bit of a Groundhog Day, right? Because, you know, then we have the level funded plans too, where, you know, you have one Adobe bulletin saying, you know, watch out for these plans. And though when it gets into the legislative process, you find out that you have many more advocates than, you know, what the regulators and other stakeholders might have otherwise thought. So, you know, I don't see much happening on the state level.
Yeah, and that's a good point. The chart you guys shared in the beginning, that it has the individual enrollment and the small group enrollment over the few years. It kind of comes to a point. Yep, exactly, Joel. I'd like to see that with 2022 data. So in, you know, the next year or the year after, we'd love to see that chart. And I do believe it's going to intersect. And quite frankly, lives are getting sucked out of that chart. And where are they going? So
Where are they going? Yeah.
right. So we need a pool of people, and they're disappearing. So I know that's for another discussion, another panel, but it all relates to each other.
Yeah, if the enhanced subsidies in the Obamacare marketplaces recede, that'll put a damper on that steep rise, and also probably the migration out of group to individual. That's one factor. But I mean, the other factor that may suggest that these options will grab purchase in the marketplace that they haven't yet. I guess that has a double meaning, but it is sort of rising premiums overall, and rising underlying healthcare costs are making standard plans more and more out of reach for so many. And unless we can get a handle on the underlying drivers, which is not the, you know, there's a lot going on in the insurance market and risk selection and all that, but the underlying driver driving all of this are rising prices in the marketplace, in the healthcare marketplace, not the insurance marketplace. I worry about things like growing hospital health system market consolidation, driving up costs even more rapidly as we go forward, and sort of the lack of ways of getting the medical spending side of this a little bit more stable. You know, and I think that may drive more of the marketplace toward fixed contribution kinds of plans, HRA kinds of plans, just because there won't be a choice.
I worry about those things too, Joel, particularly with regard to the hospital mergers. I think the horse is out of, as we used to say in Bergen County, the horse might be out of the barn on that issue, but it's something that, you know, I've been focused on for a number of years, sort of like a voice in the wilderness, because, you know, merger mania, but maybe something for the center might want to, again, I'm good at suggesting what work for others. So, something that you might, something that you might want to look at in terms of what's happening with pricing, what mergers have to do, the impact on costs.
This is the Full Employment Act for researchers, as Joel would say. Just a couple of quick points. One is somebody brought up that the Q2 22 numbers are up on the Adobe site in terms of small group, and
It's
they're
ticked down again.
yeah, 285, 600. I should say one of the caveats on those slides, they ran through 2020. We know that Adobe there was more current information, but just in terms of kind of the cutoff on, so that we could have the same cutoff period for the data on national, and on the MEPS, we only showed it through 2020, and we knew that, the trend was just continuing for 2020 through 2022. So, but thank you for that update. I guess last question here is, how can we build a professional and educational infrastructure around QSEHRA's ICHRAs for group plans that will support and maintain the revenue to insurance professionals? Does this begin at the carrier level? Anybody want to take a stab at that one?
Yeah, I mean, so I don't find the incentives all that misaligned. I think for the brokers to be talking about and potentially selling these programs, I mean, there is commissions involved. They will get paid on it. So, I think the brokers should be talking about it with their clients, and a lot of them are. I mean, this is new and we're starting out. But the bigger thing is, how do the clients motivate themselves? How do companies motivate themselves to do some self-education as well? And that's a great question. I don't know. And quite frankly, I alluded to it before. I think our system as a whole just doesn't do well in healthcare education. For example, Get Covered NJ. There is information about this everywhere, especially in open enrollment, no matter where you look. And I still speak with people who have no clue what it is. And it's not because it's not being marketed well. They came from a background where they don't understand our industry. So,
and it doesn't help that New Jersey is in media markets that are primarily based in bigger cities in neighboring states. So,
right.
but we live with that. Nothing we can do about it.
Right.
This education is, what I'm hearing is it's incredibly essential and it's incredibly difficult. But it is the starting point. That's what I'm hearing.
It is, and I'd be curious. I mean, just to kind of a final note of thinking about, we've studied health behaviors, purchasing behaviors, how people choose to get health insurance, their decisions that they make about their own healthcare coverage. And I'd be, as we emerge into hopefully what is a post-pandemic world, how has that changed? We know the workplace has changed, like people have changed. People's view about work has changed. Is that going to transition into how people may have different thoughts about their healthcare coverage, the sort of appetite for risk, those types of things? And it may be too early to tell, but I just think so many other things have changed. And certainly when we think about people's views of their employment, we've seen that change, right? And the whole dynamic change between employers and employees. Does that sort of trickle into healthcare decisions? So that's just one of the foggy ideas in my head of, something that, because it really is behaviors, and people have changed over the last couple of years. People value different things. People haven't, I don't think it's an overgeneralization that, it's certainly some preferences and appetites for risk may be changed. So I think we're just about at time. I think we got through our questions and comments, and apologies if I've missed anything in the Q&A, but I really just want to thank our panelists and Rob, Doreen, John. Kyle, it looks like had to drop off. Thank you very much for being present today, offering your comments, helping us do this work and now disseminate it, because it's so important. We don't do the work just for the, for the exercise of it. It's really important. We want to have impact, right? So let's continue to think about other ideas, other opportunities to have these kinds of discussions on topics that are mutually, of mutual interest, and certainly our partners on the call and our colleagues who've joined us on the webinar. Please do let us know. We'll be sending out a survey through Qualtrics really quick after you log off or get kicked off on Zoom. John, I actually think you put the whammy on, because when we came on, you were opining about how easy Zoom was, that you didn't have to do an update. So
I'll never say it again.
Never say it again. So anyway, thanks to everybody. Please do complete the very quick Qualtrics survey. Really appreciate everybody's support of the work and hope you all stay well and have a good week. Thanks very much. Bye-bye.
Thank you,
Care.
everyone.
Thank
Thank
you.
you.
Bye-bye. Thank you.
Bye-bye.